Welcome. This is a video explainer on what's being tested to control costs and improve value in our healthcare system. It's offered by Connecticut Healthcare Explained. I'm Ellen Andrews, Director of the Connecticut Health Policy Project. There's a strong consensus that our healthcare system is broken and needs reform. Unfortunately, there is less consensus on how to do that, who's to blame, who should shoulder the burden of reform, and what a fair healthcare system looks like. According to federal information from 2022, healthcare costs are consuming a growing share of the U.S. and Connecticut's economies. Costs for care have been rising faster than general inflation, faster than wages, and faster than the rest of the economy. There are concerns that this rate of increase is not sustainable and will force sacrifice in other important priorities. The quality of care in Connecticut is just average, despite our high costs. This falls especially hard on underserved communities, including Black and Brown, people with disabilities, the aged, and poor, that have more needs and fewer resources. Care is often divided into high and low value care. These are identified through research that distinguishes between treatments that both improve health and are cost effective and those that are neither. Unfortunately, Connecticut has a lot of room to improve on the value of care in our state. Low value care means services with little or no clinical benefit that can often cause harm. Unfortunately, low value care is common and progress to reduce it has been limited. Examples of low value care include early imaging for low back pain, diagnostic testing before low risk surgery, and antibiotics for common colds. Reform is often divided into delivery reform, changing how care is provided to patients, and payment reform, how providers are paid for the services. There's a great deal of overlap between these, and many reforms attempt to improve both delivery and cost. Delivery reforms. There are two main delivery reforms. Patient-centered medical homes are the most successful delivery innovation to date. Medical homes are primary care practices that provide extended hours, coordinate care, make appointments for patients for specialists, and follow up after ED and hospital admissions. They manage medication use and offer extra services as needed, such as nutrition and behavioral health care. Medical homes track the health and needs of their entire population of patients, anticipating and meeting those needs, both medical and social. Medical homes have a well-documented record of improving access to high-quality care, increasing both patient and provider satisfaction, preventing health problems, and reducing overall healthcare costs. Medical homes in Connecticut started in Medicaid when the program shifted away from managed care organizations, but is now common across coverage plans. Medical homes are usually paid a monthly per member fee above usual payments for services. Medical homes must be certified by an independent national certification body using evidence-based standards to receive these extra payments. The other delivery reform is accountable care organizations, also called ACOs. These are large health systems of doctors, hospitals, home health agencies, and other services. Providers are integrated into a single system, which should coordinate care and communicate better, which will improve quality while reducing duplication. ACOs are paid more if the total cost of care for their patients is lower than expected. The concept is that coordinated care and improved communication will reduce duplicate services, and that letting providers share in savings would reduce their incentives to provide low value care. Unfortunately, after decades of effort and investment, there is little evidence that ACOs have either improved quality or controlled costs. Payment reforms can be very complex, and there are several types. The terms for payment reforms are confusing, with different names for the same model and the same term being used for different models. It's important to look at the details closely of any payment model proposal. In healthcare's traditional model, fee-for-service, providers are paid for each individual service they provide. Clinicians can make more money by providing more services, necessary or not. In this economic view, to lower costs, reforms must give providers incentives to reduce unnecessary low-value care and expand access to high-value, effective care. Almost all payment reform proposals are described as value-based reforms, also called alternative payment models. Value-based reforms are designed to reward providers for both quality improvement and cost control. There is a consensus in healthcare economics that providers drive a great deal of healthcare use, both necessary and unnecessary. Unlike other things we buy, we don't have the information to judge the value of healthcare treatments. We rely on providers to make decisions and explain options. Consequently, most payment reform models try to turn incentives around to reward providers and health systems for lowering the total cost of care by letting them share in the savings. It's also important to acknowledge that simple economic models do not explain the wide diversity of human behavior. Training, culture, competition, and intrinsic motivation to heal patients are at least as important for clinicians as financial gain. There are three main categories of value-based reforms with many different terms. The underlying premise of each is to move financial risk onto providers, meaning that they make more when their patients cost less. Participation in value-based payment models is voluntary for providers and health systems, but it's not voluntary for patients. The first is shared savings, also called upside only or downside two-sided risks. It can also be called bundles, but that's generally in Connecticut. In shared savings models, providers and health systems share in any cost savings they are able to generate in the expected care costs of their patients' care. Another type is bundles, which are also called episodes of care and case-based payment. In bundled payment models, providers involved in caring for a patient during one healthcare episode are paid a single lump sum to cover all the costs of care. Examples of bundled episodes include knee replacement, breast cancer, and maternity and newborn care. Most Connecticut hospitals use bundled payment models. The intent is that bundling payment will encourage providers to coordinate care, lower costs, and improve quality. The third kind of payment reform is capitation. It's also called population-based payment, prospective payment, global budgets, lump sum payments. It can also be called modernization here in Connecticut, and bundles, again, only in Connecticut. Under capitation, providers are paid a set fee per patient to cover all the expected care their patients need for a specific period of time. If patients' costs are ultimately higher than expected, the provider practice or health system must cover those costs. If patients' costs are lower than the capitated fee at the end of the contract, the practice or health system gets to keep the extra funds. There are risks to these new payment models. Different payment models can be more or less susceptible to these risks based on their design and the protections built in. Holding providers accountable for the quality of care is key to successful reform. As one health system administrator commented, in a value-based world in which there are no quality metrics, the best patient is one you never see. The consequence of never seeing a patient, though, is that you don't perform any preventive tests and you don't pick up illnesses at an early stage. Responding to these new payment models, there are two ways for providers and health systems to save money. One is to provide care that prevents and manages costly health problems to keep people well. This is the goal of reformers. Unfortunately, there are also irresponsible ways to generate savings that harm patients and cost more. One is to deny patients needed care. This is termed underservice or stinting on care. Another way to save money is to avoid enrolling less lucrative patients. This is termed adverse selection or cherry picking. Patients could be avoided for many reasons, including if their care is not as profitable, patients who are difficult, taking more time and effort to care for, or patients who do not follow recommended treatment, patients who don't have resources to follow up on care, or patients who take extra time in visits, such as non-English speakers or people with disabilities. Two fraudulent ways to save money are to game risk adjustment and upcode in billing. Risk adjustment is intended to modify payments based on patient needs, both medical and social needs. However, risk adjustment is not a mature science, and is often gamed by health systems to increase revenue without improving quality or services. Providers and health systems can also increase revenue by upcoding or billing for more expensive diagnoses and procedures than warranted. Recognizing the risk of underservice, most payment models include quality standards that must be met as a condition of payment. However, most of the quality measures used are easy to achieve, often self-reported by the provider, and not related to better health outcomes for patients. Also, most quality standards are very low, so providers are sure to get the highest payments. Too often, provider groups that will be accountable for the quality measures are involved in choosing those same measures. And there is evidence of ACOs cherry-picking more lucrative patients. Under capitation that pays providers per patient rather than per service, providers and health systems can profit by increasing the number of patients they are responsible for and consequently paid for. This squeezes already tight clinician schedules and reduces patients' access to care. Another risk of payment models, especially those that consolidate providers into large health systems, is anti-leakage efforts. Large health systems lose profits when patients choose to or have to go to providers outside their system for care. Consequently, many ACOs use technology and provider penalties to reduce referrals to outside specialists and services. However, these efforts limit patient choice because they don't know about better options or treatments they're never told about. This falls heavily on patients getting sensitive care, such as mental health and women's health, where a good match between patient and provider is critical. Another risk of payment reform models is to public health and community service capacity, serving non-medical needs that impact health, such as housing, healthy food, and public safety. Under payment reform, the savings from community services keeping people healthy go to the medical system, rather than back to the community and public health organizations that created the savings. Asking provider organizations to take on financial risk can also backfire badly. Insurers are required to carry financial reserves if costs are high, for instance, due to a pandemic. But there is no such requirement for providers or health systems. If they miscalculate rates or hit a run of bad luck, they may have to slash unprofitable services, lay off staff, close facilities, or engage private equity investment that further erodes the finances. This reduces access to care in communities, harms the healthcare workforce, and limits consumer choice. While risk mitigation is never perfect, there are provisions that can reduce the risks. All of these require robust data and analytic systems and the will to follow through on what is discovered. It's critical to have meaningful monitoring for underservice, adverse selection, and other risks, with follow-up to fix problems when they're found. Robust quality improvement standards that are evidence-based and not easy A's are key. It's important to craft incentives and policies to emphasize health status improvements over process. Good patient surveys conducted by experienced independent groups can be incredibly helpful. Monitor patients out-of-network care for outliers or changes over time to ensure consumer choice, and simple and confidential patient complaint processes with meaningful follow-up on cases and trends. So which reforms are working? For delivery reform, patient-centered medical homes are the only reform with improving access to care, with clear evidence of improving access to care, better quality, improved patient and provider satisfaction, and controlling costs. Connecticut has many medical homes, but there is room for growth. Accountable care organizations have a disappointing record toward reform goals. Despite decades of effort and significant investment, ACOs also consolidate providers into large health systems, which can then use their monopoly power to drive up prices. In payment reform, there are mixed reviews of various models with no clear success story. Despite significant investments in 54 innovative trials over a decade, according to CMS's former head of innovation, the vast majority of models have not saved money, with several on pace to lose billions of dollars. Reform is hard, and healthcare providers and administrators are overworked. Workarounds and band-aids are faster and cheaper than overhauls. Players have very different perspectives and often can't see other parts of the system. Pulling one thread can have important unintended consequences. Challenges to reform include groups disadvantaged by reforms can be powerful lobbyists to resist change. Reform requires significant investments. Value-based reforms require data collection and analysis, and that data must be high quality, accurate, and timely to be actionable. Reform brings more uncertainty about revenues and costs. There often isn't enough evidence about which treatments are and aren't effective. Increasing consolidation in healthcare markets may reduce fragmentation, but it also raises prices and profits. And understandably, providers may resist being held responsible for health outcomes when so many determinants and patient behaviors are beyond their control. Incentives to collaborate and lower costs under value-based purchasing may be less than continuing as usual. Reform may not be worth it for some providers in large health systems. Hopefully, this has helped you understand efforts to reform healthcare. For more information, visit our reform chapter in CT Healthcare Explained at cthealthexplained.org.